Hi everyone. This video is on how to diagnose appendicitis on ultrasound. So here's an image of a normal appendix from an article. It's going to be less than 6 millimeters. In this case, it's 3 millimeters. You have to see it all the way, ideally from the base to the tip, because there is such a thing as tip appendicitis. It will be compressible. The surrounding fat won't be indurated and abnormally hyperechoic. This image, I think, has a high gain, but you can generally use the subcutaneous fat as your internal control as to whether the periappendiceal fat or the mesoappendix is hyperechoic. This is another normal appendix ultrasound image. Again, a non-dilated. This is probably less than 6 millimeters. It does have gut signature. It's not fluid-filled or distended with fluid. You can see it all the way to the tip. There's no periappendiceal fat stranding which would present as hyperechoic fat. This is a normal compressible appendix on transverse view. Again, you see the layers of the gut signature of the appendix. Now, here's an example of appendicitis. This patient has a 10 millimeter caliber appendix, really hypoechoic, a lot of fluid inside. And we see the blind end, so that helps confirm it's indeed the appendix. We actually lose that kind of nice gut signature in this particular case. And importantly, you can see that the periappendiceal fat compared with the subcu fat is hyperechoic diffusely here on the longitudinal view, and then here on the transverse view, very, very hyperechoic periappendiceal fat. Again, here's your subcu fat as a reference for internal control. There should generally be the same appearance on any modality, really. Be careful with just looking behind the appendix. As you know, there can be posterior acoustic enhancement. So don't just rely on that alone. This would be non-compressible, given how distended it is, and it's 10 millimeters in caliber. Real quick about the caliber, use that 6 millimeter cutoff to exclude appendicitis if it's under 6 millimeters in caliber. If the appendix is greater than 6, or at least 6 millimeters, look for secondary signs, signs of inflammation to diagnose. Do not diagnose appendicitis on caliber alone. According to StatDX, for example, greater than 40% of PEDS patients will have calibers greater than 6. So do not hang your hat on just the 6 millimeter caliber. Look for signs of inflammation as well. Here's appendicitis with 2 appendicolits. This is the blind end over here. You have 1 stone, but this is the reason for the appendicitis. It's obstructed by this shadowing appendicolite or stone closer to the base and really distended, thick wall, fluid-filled, hyperechoic fat around it. This is a case where you see, again, a distended appendix. You have the obstructing stone. This is the blind end. That's the stone proximally. And this is the hyperechoic indurated fat. And then you have some free fluid along that indurated fat, hyperechoic fat. At this point, hard to be sure whether it's perforated or not. If you have an abscess, that's pretty much slam dunk on any modality that is perforated, but free fluid, it's kind of plus minus. You can suggest it, but it's not 100% specific. Suspicious though, but they can clinically examine to tell if there is indeed perforation. There's now in this patient a complex fluid collection, not simple, as indicated by the arrows. When this happens, the appendix is usually hard to define in terms of its wall because of the perforation and abscess development. Just a quick note on a mimic here. This is hyperechoic feces that's impacted within the appendix. So it will be distended by default because of the content within it. But as you notice, the surrounding fat is actually not hyperechoic. There are no fluid collections. So in this case, much like just as a dilated appendix with no other findings of appendicitis, same thing. Do not call it just on the basis of the distension. in the presence of fecal impaction. When there's no other findings of appendicitis, just do not call it. Here's another mimic, potentially. This is terminal ileitis. You can see especially the submucosa here is thickened. Hopefully you'll have good CNS by the text. Maybe you can find the actual normal appendix. If not, the appendix does not peristalse, whereas the rest of the bowel will peristalse. Even when inflamed, it could be diminished peristalsis, but hopefully you might be able to have the tech document peristalsis along this inflamed bowel and then exclude appendicitis in this case. And that's the end of the video. Feel free to ask me any questions.